Welcome to the Deep Dive, your shortcut to being genuinely well-informed. Today we're pulling back the curtain on a silent, relentless adversary. It affects a surprising 1% of the global population, often starts subtly, easily dismissed, yet it can inflict profound, irreversible damage if those warning signs aren't caught quickly. We're dedicating this deep dive to rheumatoid arthritis, or RA. It's a chronic systemic autoimmune disease, and honestly, it's far more complex than just achy joints.
Yeah.
Our mission is to really distill the most critical insights from our source, Rheumatoid Arthritis, the GP's complete guide. We want to equip you with a solid understanding of RA's true nature, why early action is so vital, and what holistic care actually looks like. Before we really dig in, let's anchor ourselves with a few facts. Globally, RA hits about 1 in every 100 people. And here's something that stands out. Women are 3 times more likely to develop RA than men, typical onset, often between 30 and 50. That's often a really active, demanding time of life. So what we uncover today could be incredibly impactful, maybe for you or someone you know.
You've hit on a really crucial point there about the early signs, how often they're missed. This deep dive isn't just about symptoms and treatments. It's really about understanding this critical concept our source calls the window of opportunity.
Okay.
It's this brief, crucial period where intervention can fundamentally change a patient's whole life trajectory. It can prevent years of irreversible damage, preserve function. Missing that window, well, it carries pretty significant consequences.
That idea, the window of opportunity, it really underscores the urgency, doesn't it?
Absolutely.
So let's start with the basics. What is rheumatoid arthritis, really? Is it just another type of arthritis, or is there something, uniquely insidious about how it works?
Yeah, it's much more than typical arthritis. Our source explains RAA as a chronic autoimmune disease. So think of it like this. Your immune system, right, it's designed to protect you from viruses, bacteria, invaders. But in RA, it essentially gets confused. It mistakenly sees your own healthy tissues as a threat and launches an attack. And in RA, that attack is primarily aimed at the synovial joints. Those really movable joints like your knees, fingers, wrists.
Right, the ones with cartilage and fluid.
Exactly. Where 2 bones meet, cushioned by cartilage, all in that fluid-filled capsule. This immune system, betrayal really, leads to persistent inflammation of the joint lining. That's called synovitis. And over time, that inflammation just systematically erodes the cartilage and even the bone itself.
So it's like a betrayal from within, dismantling the very things that let you move. And I gather it's not just one joint. Our source mentions symmetric inflammatory polyarthritis. What does that actually mean for someone?
Precisely. That phrase, symmetric inflammatory polyarthritis, tells us 2 key things. Polyarthritis, that means it typically affects multiple joints, not just 1 or 2. And symmetric is crucial. It means it often hits the same joints on both sides of the body. So like both wrists or the knuckles on both hands. It's a mirror image of inflammation.
Gotcha.
But what's even more critical and often overlooked is that RA isn't just stuck in the joints. Our source highlights its extra-articular involvement.
Extra-articular,
Yeah.
meaning outside the joints.
Exactly. It can extend its reach to other vital organs, affecting everything from your lungs and heart to your eyes, even blood vessels. It's a systemic disease. It impacts the whole body.
That's a powerful and, frankly, quite alarming distinction. The idea it can spread beyond the joints really paints a picture of its severity. And I imagine without early effective treatment, this progression isn't just uncomfortable. It must lead to severe joint deformity, significant disability.
Oh, absolutely. And those systemic complications you mentioned, they all dramatically impact a person's quality of life. The urgency of understanding this, it just can't be overstated. Indeed, the consequences of inaction are profound. And just to reemphasize the demographics, about 1% globally, that 3.1 female to male ratio we talked about, and usually starting between 30 and 50. But it's not entirely random. There are identifiable risk factors that increase susceptibility.
Okay, so genetics play a part. Our source mentions HLA, DR4, DR1. But what really jumped out at me, and I think might surprise listeners, is how powerful environmental factors are. Smoking, specifically.
Yeah.
It's flagged as the strongest modifiable environmental risk. That's huge, isn't it? Something you can actually do something about.
It absolutely is. And it's a point that really can't be stressed enough. Smoking significantly increases both the risk of getting RA and the severity of the disease once you have it.
Wow. What other factors contribute?
Well, beyond genetics and smoking, our source also points to periodontal disease, that's severe gum disease.
Really, gum disease?
Yeah. Also, obesity and certain hormonal influences seem to play a role. When you connect this to the bigger picture, recognizing these risks, especially the ones you can modify, like smoking. It empowers people to take preventative steps, and it helps clinicians spot those at higher risk sooner, which, leads to the next important question.
Yeah.
What do these symptoms actually look like in real life, beyond just general achy joints?
That's the key, isn't it? Because those early signs can be subtle, easy to mistake for just, overdoing it or getting older. Our source describes the early joint presentation. Symmetrical small joint involvement. When we say small joints, what are we talking about specifically?
Primarily, we're talking about the MCP joints. Those are your knuckles, where your fingers meet your hand.
Okay.
The PIP joints, the middle joints of your fingers, and the wrists. A real hallmark symptom and a critical differentiator is morning stiffness.
Right, that's stiffness.
And it's not just a few minutes. It often lasts 30 to 60 minutes, sometimes even longer. One case study in our source mentioned over an hour.
Over an hour just to get moving properly.
Yeah. But here's the crucial bit. This morning, stiffness actually improves with activity. Unlike, say, mechanical pain that might worsen when you move, getting up and moving around helps ease RA stiffness.
That's a key distinction.
It is. And during active inflammation, these joints will usually have pain, swelling, tenderness, warmth. But it's important to note they're typically not red, unlike conditions like gout.
Okay.
And as the disease progresses without treatment, the inflammation often spreads. Larger joints like knees, ankles, shoulders, elbows get involved.
Many of us know morning stiffness, but needing over an hour for your hands to work properly, that paints a very different picture of daily life. And if it's untreated, the visual impact, the deformities, what does the source describe there?
It can be devastating without proper treatment. Imagine fingers bending unnaturally towards the pinky, that's called ulnar deviation.
Oh, what?
Or joints stiffening into positions like a swan's neck, or what's called a boutonniere deformity. You might also see a Z-thumb. These aren't just abstract medical terms, they're visible signs of destruction. They make simple tasks incredibly difficult, profoundly altering someone's life and independence.
Those are stark reminders. But you also mentioned the systemic, the extra-articular features earlier. These aren't minor things, right? They signal something more serious.
Absolutely not minor. These extra-articular features often signal more severe disease. They demand urgent specialist attention beyond just pervasive fatigue and that general feeling of being unwell malaise, which is common. You can see things like rheumatoid nodules.
Nodules, like lumps.
Yeah, firm lumps under the skin, often over pressure points like the elbows.
And it goes further. The source mentions eyes, lungs, heart.
Certainly. In the eyes, RA can cause scleritis inflammation of the white part of the eye or severe dry eyes. In the lungs, we sometimes see interstitial lung disease.
Scarring in the lungs.
Essentially, yes. Scarring around the air sacs, making breathing difficult. And critically, RA can affect the heart, leading to things like pericarditis, inflammation of the sac around the heart, and importantly, an increased risk of heart attack, myocardial infarction. There's also anemia of chronic disease. The body struggles to make enough red blood cells because of the inflammation.
Okay, so this really highlights that systemic nature. It's not just about the joints at all.
Exactly. And recognizing these non-joint symptoms early is often a critical signal for clinicians. It suggests a more aggressive disease course needing immediate attention.
So REA is a full body experience, not just a local ache. And that urgency leads us straight to early diagnosis and referral. What does immediate attention mean for a GP? Our source gives clear red flags, non-negotiable warnings needing urgent specialist referral. What are they? Why so critical?
These red flags are like emergency sirens, really. First, rapid joint destruction. So severe pain with quick, aggressive joint damage progression, that needs immediate attention. Second, any extra articular involvement. New lung issues, eye problems, heart complications that signal severe systemic disease. Third, and this is especially urgent, cervical spine involvement. The neck bones. If they shift dangerously subluxation, they can pinch the spinal cord. That's a medical emergency. Needs immediate action to prevent permanent damage.
A true emergency.
Absolutely. And finally, severe systemic symptoms. Things like major weight loss, high fevers, persistent malaise alongside the joint pain. Need to rule out other serious stuff like infection or malignancy, as well as considering RA.
It sounds like the GP, the primary care doc, plays a huge role in spotting these dangers.
Right.
What's their diagnostic approach when they first suspect RA?
Yeah, the GP's initial moves are vital. If they see someone with that symmetrical joint pain, that morning stiffness dragging on over half an hour, their RA radar should definitely ping.
Right.
Then it's about getting the right blood tests. a complete blood count, CBC, ESR, and CRP, inflammation markers, rheumatoid factor, RF, and crucially, anti-CCP antibodies.
Anti-CCP.
Yes, specific RA markers. Also an ANA to screen for general autoimmunity and baseline kidney, UNE, and liver function tests, LFTs, before starting any treatment. Imaging 2 x-rays of hands and feet. Though early x-rays might look normal, so clinical judgment is key. Ultrasound or MRI are more sensitive for spotting early synovitis.
You mentioned ANA. What does that generally suggest? And then the anti-CCP antibodies. The source says they're more significant than RF. What's the key insight there?
Well, ANA, anti-nuclear antibodies, they basically show antibodies targeting the body's own cell components. Finding them suggests an autoimmune condition, but it's not specific just to RA.
Okay.
Now, anti-CCP antibodies, they target a specific modified protein often found in RA patients. It's a trelinated protein. This makes them much more specific than rheumatoid factor RF. RF can be positive in other conditions or even in healthy people sometimes. More importantly, our source emphasizes anti-CCP is a better predictor of how aggressive, how damaging the RA might become at erosive progression.
So a positive anti-CCP is a pretty strong signal.
Yeah, a high positive anti-CCP often points toward the more severe disease course, greater chance of permanent joint damage.
Okay, let's dig into this. The speed here is vital. That window of opportunity our source mentions. What does that mean practically for the GP's role once they suspect RA?
The GP needs to act fast, recognizing that crucial window. It refers to the time frame for getting the patient to a rheumatologist. Ideally, within 3 months of persistent synovitis.
3 months.
Even better, within the first 12 weeks. This urgency is paramount because delaying specialist care beyond this really ups the risk of irreversible joint damage, long-term disability.
So what can the GP do in the meantime?
While waiting for that specialist appointment, they can provide some symptomatic relief. Short-term NSAIDs, non-steroidal anti-inflammatories, maybe brief courses of steroids, oral or injected, for severe symptoms. But, and this is key, these must not delay the specialist referral. They're just bridging therapies, not the long-term fix.
Right, just managing symptoms temporarily.
Exactly, and patient education is huge here too. Explaining it's a chronic disease, why early therapy matters, sticking to meds, lifestyle changes, empowering the patient right from the start. It's fascinating, this interplay between primary care and specialists. A GP spotting those red flags, ordering the right tests like anti-CCP that can save critical weeks or months. It can completely change a patient's path.
So once the specialist diagnoses RA, what's the ongoing management? Our source talks about DMARD therapy. What are DMARDs? How do they fit in?
Right, DMARDs, disease-modifying anti-rheumatic drugs. They're the absolute cornerstone of RA management. Unlike just painkillers, these meds don't just mask symptoms. They actively slow down the disease progression, help prevent that joint damage we've been talking about.
Okay, so they actually modify the disease course.
Precisely. Methotrexate is usually considered the gold standard first-line DRN. It's effective, generally well tolerated. Other conventional options are things like leflunomide, sulfasalazine, hydroxychloroquine. Now, if patients don't respond well enough to these, or if their disease is particularly severe, then we move to biologics and targeted synthetic DMARD.
Biologics. Those sound more advanced.
They are. Things like TNF inhibitors, rituximab, tocilizumab, J inhibitors. They target very specific parts of the immune system to really dampen down that inflammatory attack. Corticosteroids like prednisolone are also used, but typically as that bridging therapy we mentioned, maybe for 3-6 months while waiting for the DMARDs to kick in fully because they can take weeks or months to reach full effect.
Makes sense. And the GP still has a vital role, even with the rheumatologist involved, monitoring treatment.
Oh, absolutely. The GP remains crucial. Before starting DMARDs, they'll do a baseline assessment, CBC, liver, kidney function, screen for hepatitis B, C, as some meds can affect these. Then, regular monitoring is non-negotiable. Monthly blood tests initially, then maybe every 3 months once stable, checking meticulously for potential side effects.
Like what kind of side effects?
Things like low blood cell count cytopenias, liver toxicity, kidney function changes. GPs also need to be vigilant for signs of infection, unusual bleeding, a persistent cough, signs of liver issues. It's usually managed through what's called a shared care protocol. Good coordination between the GP and the rheumatologist is key.
Beyond the RA itself and the meds, the source really emphasizes monitoring comorbidities, other health conditions often linked to RA. This was a real aha moment for me about the systemic impact. What are the key risks?
This is critical. It's where that holistic understanding really comes in. RA significantly increases the risk of several serious conditions. Cardiovascular disease, for instance, The risk is comparable to having diabetes. Our source notes a 50% increased cardiovascular risk.
50%. Wow.
Yeah. Higher chance of heart attack, stroke, often driven by the chronic inflammation itself, speeding up atherosclerosis, hardening of the arteries. So regular screening and aggressive management of traditional risk factors, cholesterol, blood pressure, are essential.
Riddles.
Osteoporosis, brittle bones. That's another major concern. From the chronic inflammation, maybe reduced mobility, sometimes steroid use, so bone density monitoring is crucial. And mental health, chronic pain, inflammation, disability. It takes a toll. Our source mentions a 30% depression rate. So regular mental health assessments support vital parts of comprehensive care.
So it's not just treating RA, but actively preventing this cascade across the body and mind. What about preventive care? Vaccinations, especially with immune suppressing treatments.
Another absolutely critical aspect. For RA patients, especially on immunosuppressants, certain vaccines are essential. Flu, pneumococcal, COVID-19, HPV, ideally given before starting these therapies.
Okay.
Yeah. And it's vital to know, live vaccines are generally contraindicated once someone's on biologics. They could pose a risk to an immunosuppressed person. Patient education on infection prevention is also paramount. Simple things, hand hygiene, avoiding sick people, and regular screenings. Annual skin checks, TB screening before starting biologics, all part of that preventive plan.
And any other specific complications to watch out for?
Well, we aim to prevent joint deformity and disability through early therapy, physiotherapy, occupational therapy, maintaining function, adapting activities. Infections, as we said, are a heightened risk with immunosuppressants. Patients need prompt medical attention for any concerning symptoms. There's also a slightly increased cancer risk, particularly a lymphoma and skin cancer with some biologics. Needs regular screening, sun protection. And finally, for women of childbearing age, pregnancy planning is crucial. Methotrexate, for example, is strictly contraindicated in pregnancy, causes birth defects. So medication switches need careful planning with the rheumatologist well in advance.
Wow, that's a lot to manage. A true multifaceted approach. But it's not all about meds and monitoring, is it? The source highlights some really powerful, actionable lifestyle interventions. What are the keys there?
Absolutely. Lifestyle changes play a huge, empowering role. Smoking cessation, probably the most impactful. We keep saying it, but it's the strongest environmental risk factor, worsens the disease. Quitting is essential.
Right.
Regular low-impact exercise, physiotherapy, vital for joint mobility, muscle strength, protecting joints. Healthy diet, weight management helps reduce inflammation, takes stress off joints, lowers that cardiovascular risk.
Makes sense.
And crucially, psychosocial support. Patient groups, occupational therapy, mental health resources. Coping with a chronic condition is tough. Support improves well-being. It really is a team effort, including the patient themselves.
This really brings home that RA management is a marathon, not a sprint. Involves the whole healthcare team and a proactive, empowered approach from the patient.
Yeah, stepping back, it powerfully underscores that RA management has to be holistic. It's not just treating the disease, but preventing those cascading effects, supporting the person's overall well-being, which raises an important question. How does all this actually come together, in a real-world scenario, from first symptoms to effective management?
To bring this all to life, our source gives us a great case study. Sarah, a 42-year-old teacher. Her initial symptoms sound spot on for early RA. She came in saying, I've had stiff, painful hands for 3 months, especially in mornings. It takes over an hour to grip properly. My wrists, knuckles are swollen, tender, and honestly, I'm exhausted all the time.
That's a perfect picture of early RA symptoms, isn't it? Her story immediately flags those key things. Symmetric small joint involvement, hands, wrists, prolonged morning stiffness over an hour, systemic symptoms, that exhaustion, all that together raised a very high suspicion for rheumatoid arthritis.
So what were the immediate next steps for her GP? Given that strong suspicion and that urgent window of opportunity.
Right. The GP immediately ordered those key investigations. RF, anti-CCP, ESR, CRP, CBC, kidney and liver function tests, plus hand and foot x-rays. Recognizing the urgency and for immediate symptom relief while waiting for the specialist, a short course of prednisolone, 15 milligram daily, was prescribed. And crucially, an urgent rheumatology referral was made within 2 weeks, getting her into that critical window.
And the lab results for Sarah, what do they show?
They clearly confirmed the diagnosis. Her RF was positive, 120 IU/mL. Her anti-CCP was strongly positive at 85. I'll remember, that's a powerful predictor of erosive disease.
Right, the specific one.
Exactly. Her inflammatory markers, ESR and CRP, were also both elevated. Based on all this, the rheumatologist promptly started her on methotrexate, 15 milligram weekly, with folic acid to minimize side effects. The GP's role then shifted to that ongoing monitoring, monthly blood tests, patient education, coordinating care via that shared care protocol. And the good news, Sarah showed significant improvement within 3 months, preventing that severe irreversible damage.
Sarah's story really shows exactly how those early symptoms, swift action, the right lab tests, and that coordinated approach can lead to a really positive outcome. It's a powerful example of why understanding this is so vital.
What's really compelling is seeing how all the pieces we've discussed fit together. The symptoms, those specific markers like anti-CCP, the prompt referral hitting that window, rapid treatment initiation, it all converges to genuinely change a patient's life for the better. Sarah's path was fundamentally altered. That's the power of early intervention right there.
It's a powerful illustration. Now, just to help everyone really lock this in, let's distill this down. The absolute key take-home messages for you.
Okay, first, early recognition. Think RA in adults with symmetrical small joint pain, morning stiffness over 30 minutes. Second, urgent referral. Get to rheumatology within 3 months of persistent synovitis. Prevent that irreversible damage. Third, essential tests. Order RF, anti-CCP, ESR-CRP, baseline bloods for assessment and monitoring.
Fourth, remember bridging care. Manage pain short-term, but don't delay specialist DMARD initiation. Fifth, comprehensive care. Critically important. Monitor for cardiovascular disease, osteoporosis, depression, infections throughout treatment. And sixth, lifestyle focus. Smoking cessation and patient education aren't optional extras. They're absolutely crucial components of managing RA effectively. This deep dive has vividly shown the transformative power of early diagnosis and comprehensive, multifaceted management in rheumatoid arthritis. Understanding diseases like RA isn't just academic, is it? It equips you with knowledge that can genuinely impact lives, maybe your own, maybe those around you.
Yeah, this deep dive really highlights how complex, how systemic an autoimmune disease like RA can be, sort of silently waging war on the body. It really makes you wonder, doesn't it, what other conditions might be quietly impacting our bodies in ways we're only just starting to grasp, where early recognition truly holds the key to a better future and where our knowledge can literally change lives.
That's a fantastic, thought-provoking question to leave us with. Thank you for joining us on this deep dive. Keep exploring, keep learning, and we'll see you on the next one.